This conference will now be recorded.
Okay, so what we're going to talk about today is the certification and the recertification for Med A. So there is within the Medicare manual in Chapter 30, we have the subsection that talks about certification and recertification by physicians for extended care. And the extended care services are those that are provided in the nursing home after someone's been in the hospital within the 30-day requirement under normal times. Also in Chapter 6, you will find similar verbiage about your certs and recerts and who it is that can sign these. So as we look at this, the important thing to understand is that payment for covered post-hospital services can only be made if the physician has taken care of this. So we need to have required certs and recerts over a period of time in order to be able to be paid. All right, we really shouldn't even be submitting a bill if you don't have these things in order, which is why this is very important. I know there's been a lot of changes since I've come on board in October, and you might feel like they're coming on you fast, but I'm trying to deal with a lot of the foundational things first to make sure that we have a nice solid standing at a ground level, and then continue to build on things that are a little bit more elaborate. So we need to take care of some of these things that are the foundation of how it is that we secure our payment and make sure that it's appropriate. So who can sign the certification or the recertification? Well, obviously the attending physician or any physician on staff of the nursing facility who has knowledge of the case. So that could be your medical director. In a situation where we have delayed certifications in a large number, it is fine, perfectly fine for a medical director to sign all of those because he is ultimately responsible for all the patients in-house anyway and should be familiar. Or you can use a physician extender. And so that would be your nurse practitioners, your NPs, a clinical nurse specialist, APRNs, or a physician's assistant. But those people cannot have a direct or indirect employment relationship with the facility. They have to be paid by the physician in order for those signatures to be appropriate, all right? Because they don't want it to be that there is some sort of a conflict of interest in these people signing this stuff for us. So this is what the new cert looks like that I shared with you guys. And we're going to go over it a little bit and talk about it, and then we'll talk about the upload into PCC. So the beneficiary's name must appear on the cert as it is on the common working file. All right, so if there's a middle initial, it needs to include the middle initial. All right, even if you think it's misspelled wrong, however it is on the common working file is how it is that it needs to be put on here. The admission date is the first day of Med A, not necessarily the first day that they've come into the facility. And medical record number is optional. All right, this would not be considered invalid if you did not have a number here. It should not be someone's social security number. So if you have a medical record number, the PCC number, any of those can go there. And if not, it can be left blank without voiding the certification. We strive for the first signature to be signed by days 3 to 5. If you were to look at the regs, there's no specific time frame for this initial cert, except to say that it needs to be signed as close to admission as reasonably possible. Okay, so that leaves a lot of ambiguity into whether or not it needs to be done by a certain time. So we strive for 3 to 5 because typically the doctor should be seeing the patient within that time frame. And it must be dated by the doctor. It's very evident when someone puts the admission date up here and then you look at the date, and let's just say someone has something that's very significant to their handwriting. They'll put a line through their 7, for instance. What's the likelihood that the doctor signing this is putting a line through their 7 as well? So there are often times that you can look at these two dates and recognize, I'm not a handwriting expert, but you can look at these and you can make the assumption that the doctor did not sign it themselves, and they must. They must date it themselves. So then you move into the first recertification. We're going to talk about 3 of the things that we would be skilling somebody for on this page, and then we'll move to the next screen. But direct nursing skill, if we're going to check this off, then it's only if they're receiving this higher level of skill as outlined in Chapter 8 of your Medicare manual. So although this is not all inclusive, it's things such as IV meds or fluids, a trach or a vent, multiple stage 2s or a single stage 3 or stage 4 pressure ulcer, new colostomy, a tube feeding that meets the criteria, basically NPO, infected surgical wound requiring dressings, a daily IM injection. Then we move to management of plan of care. If you're going to check this off as one of your skills, then it needs to get checked when the level of care planning is above and beyond what you're going to do for every other admission and readmission. So just because you're establishing a care plan for someone as a new admission and using all of your OBRA regs, that has nothing to do with rising to a level of skill. All right, so what you should expect to see is evidence of frequent review, frequent modifications and changes of the specific interventions. So when you're skilling using this, you don't want it to be generic care plans like risk for weight loss, and then you just say weigh is ordered or weekly weights. You should be identifying the weight. You should be identifying whether you're giving supplements. You should be identifying the percentage of those supplements they're taking, and do you need to add more? It should be very, very intimate in what you're seeing. And the same thing, risk for impaired skin integrity. You can't have just these generic, reposition every 2-hour type things, or skin barrier, or a pressure redistributing mattress. That's not going to cut it if you're skilling someone for management of plan of care. And then we have teaching and training. So if you're going to skill someone for this, then it's not one-liners in the medical record that say diabetic teaching done. That's not going to cut it. That doesn't rise to a level of skill. You need to identify what's the knowledge deficit. Is it medication related? Is it disease related? Is it them providing their own ostomy care or their own wound care or catheterizing themselves? What's the knowledge deficit related to? What are their barriers to the teaching and training? Are they not motivated? Do they have a language barrier? Do they have a cognitive impairment that prevents that? What are the methods that we're using for teaching and training? Who are we teaching, and what is their response to the training? When your medical record identifies all of these things, then you've risen to a level of teaching and training at a skill. So the one that we're going to deal with primarily is observation and assessment. There really should be little to no instance in which we don't check off observation and assessment on our first recert. Okay, as the patient's stay progresses, it might not still be appropriate the next time you recert, because you've already observed and assessed and you know that this patient is basically at a baseline or stable, which are words that we try not to use too much in Medicare documentation. In typical times, these folks are coming from a recent hospital confinement, and in most cases with significantly comorbidities. All right, so how is it that we wouldn't be monitoring them for what they were just in the hospital for? 3 days, 4 days, 5 days, 2 weeks, right? They come to us, they're not just automatically, have all these things resolved. There are things that are going to still be there and could be exacerbated or even resurface after they've come to us. So pretty much on the recert, you should expect to see observation and assessment. The primary reason for SNF stay has to match what you're going to put on your MDS for that same question. This is not something that you get to choose which you're going to put here based on which one pays more. Primary reason for SNF stay is exactly that. There are occasions when you will have two that seem to have the similar level of bulk of care, and it might be appropriate for you to decide between the two. But more often than not, the primary reason for SNF stay is going to be pretty indicative. And you're not going to be trying to make decisions about, well, I could change it to this because I'm going to get acute neuro. Well, if that's not the primary reason, it doesn't matter that it pays more, it's not appropriate. So we want to put that on there so that everybody's on the same page with what it is we're saying is the primary reason for this person's stay. Then we move on to the therapy aspects of the skill. So do they have physical therapy? Do they have occupational therapy? Do they have speech therapy? All right, so you'll check those things off based on the orders and evals and continuations, clarifications to treat, whatever you're going to have there. Next, we're saying that we're estimating that the additional period of inpatient care is going to be either a number of days or a number of weeks, not both. And I've looked at a lot of certs where everybody's putting 30 days, 30 days, 30 days as they recert someone. That's not what you should have. You should be showing, basically painting a picture through this cert of the patient's progression through their stay. So although you might start with 4 to 6 weeks on your first recert, the next one might go down to 2 to 3, and the next one might stay at 2 to 3 if they're not improving at the level we thought they would, but it might go down to 1 to 2. So you should see, as you look at a cert, the progression of the person's stay and the outcomes based on the therapies and the interventions that we're providing for these patients. So next we have the plans for post-SNF care. So it can be a little misleading. Not everybody's leaving SNF care. So we do have long-term placement that you can check off here. But typically it wants to know when this person is cut from skill, what's going to happen? Are they going home with home health? Are they going home without home health, but they'll follow up with their doctor, so office care? Or are they going to stay long-term placement? The other's there just as a default. Continued SNF care is for the same condition which the patient received inpatient services. This answer has to be yes, okay? If it's not, then by regulation, you have no business skilling the person, because it tells you here, it must clearly indicate that the post-hospital extended care services were required to be given on inpatient because of their need for skilled care based on any of the conditions for which they were receiving hospital services. That's exactly what this statement says. And if it doesn't say yes, and the doctor has signed it and dated it, it doesn't make a difference. He didn't affirm that this was why we were certifying the person. It doesn't matter that you're doing all of this. If he doesn't affirm, she doesn't affirm the fact that it's related to the hospitalization, then it can invalidate the cert. So you should be checking off these yes questions for the doctor prior to them signing it. So I agree with the above documented reason. Again, if this is left blank and you put it in front of the doctor to sign and they sign it, and this, even if they said yes and there's nothing up here, what are they attesting to? The above documented reason. If you've left this blank and the doctor signs it, you can't go back later and put something in there. That's illegal. So you want to make sure that these things are filled out before you're putting it in front of the doctor for a signature. So the first recert has to be signed by the 14th day of the stay. And a lot of people get this wrong in that they add 14 days from admission, when in fact, admission day is day 1. So it's admission plus 13 days for your due date. And it, again, must be dated by the doctor. And even on the cert at the top, you'll see that it's telling you this first recert is required on or before the 14th day. If your doctor typically signs that first cert, that's days 3 to 5, and this first recert on the same day, you want to make sure all of this is filled out before you put it in front of him. Because once again, if he signs the 5-day, you know, the initial, and then signs this one and nothing's here, you cannot add anything. All right, that's illegal. Cannot add anything once the doctor has signed and dated. Everything above that has to stay the same. Also, if the doctor signs the first 2 at the same time, you might run out of one page to be able to cover somebody through their whole stay, especially if the doctor also signs the next recerts a few days early. You need to make sure that the last date on the cert, which would be good for 30 days out, covers the last covered day. Other than that, you might have to start a second page to get through the entire stay. So now we're looking at, we've got this 14-day recert here, and the doctor signs it on 10/20. So what's the next due date? All right, people go through and start putting due dates all down the side right when somebody's admitted. You can't do that because this date determines this first due date. And you want to make sure that you're paying attention to the months that have 31 days. So 10/20, some people instinctively would just say the next one's due 11/20. However, you got 31 days in October, and if you put down 11/20 and the doctor signs 11/20, you set that doctor up to be out of compliance, right? Because you know that they're not reading all this other stuff, right? They're not looking at all of these details. They're relying on you to say this is due by this date, and if you put it in front of them, they're supposed to sign it for whatever date it's put in front of them. Right? They don't have to say 11/19. They can do it 11/17. They can do it 11/15. And if you give it to them late or they get to it late, they sign it 11/21. Just because you've identified a due date is not telling the doctor that it's okay for him to put that date there. All right, so you've got your cert all signed, you're all copacetic with that. Now you're going to scan it into a document to your computer. I would suggest you create yourself a folder that keeps certs so that you know where you're always going to pull those up if you haven't done that yet. You go into PCC, into documents, and you would be creating a new document for the first time you're putting a cert in for someone. When you hit new document, the screen is going to open up. It will be the date that you're doing this. You will want it to be the other category, and then you will want to create a name for it. Physician cert, recert, Med A cert, whatever you want to do so that it's consistent in your building and we know what it is. You will then need to go and find the file that you scanned somewhere on your computer. Once you locate it, you'll hit upload, and then we will be able to see that cert within the documents. When it's time to upload a more recently signed cert for the stay, I would say upload the new cert first and then delete the old one. So you should all now have the capability to delete those. I think when I first sent the information out to you guys, some folks sent something back saying they weren't able to do it. I believe Athena made the change for us so that you are able to now do that. If you can't, you should test it at this point just so we can get it squared away.